Now joining us, we have Stacy Gaither, the Director of Simulation Research, Pediatric Simulation Center. She's the Program Coordinator for the Coaches Program. She will be presenting on empowering community healthcare education, the creation of Children's Hospital Community Healthcare Education Simulation Program. We would now like to welcome Stacy. Let's welcome Stacy.
Thank you, Lonnie. Next slide, we can go ahead and go to the next slide here. Okay, so today, thank you guys for letting me talk and attending my presentation. We're going to talk a little bit today about exploring some challenges and gaps in pediatric readiness here in Alabama. We're going to talk a little bit about the steps involved in creating an outreach simulation program and more about how we can bring our hands-on training and education directly to the healthcare providers across our state. And after that, we'll dive a little bit more into our actual program, what it is, how it works, and why it's a key part of our approach to improving pediatric healthcare statewide. And then finally, we'll reflect on some lessons we've learned along the way, share some of our successes as well as challenges that we have faced so that we can continue to improve and grow our initiative. Next slide. So community hospitals are a necessity for sure in every state, but nearly 90% of children who need emergency care usually end up in their community emergency departments. Most of these are for lower acuity problems like minor injuries or common illnesses. But startlingly, even over 80% of pediatric traumas are initially treated outside of pediatric trauma centers. And so this means that most community hospitals are handling pediatric emergencies that are often high stakes for them because they're low occurrence events. And since they don't happen frequently, they sometimes panic a little bit because they require a little different care than the adults that they're used to. And unfortunately, many of the community hospitals just simply lack resources or the experienced providers to care for critically ill children, putting them at greater risk during these rare critical moments. We have found too that many of the general emergency department providers report that they have minimal exposure to pediatric critical care training during their residency. And so they said even the ones that did have exposure during their training often found that their knowledge and skills related to pediatric care seem to deteriorate over time because they don't have regular hands-on practice, and it's hard to maintain their proficiency because of that. And so the lack of practice and exposure leads to a decline in their confidence and competence, particularly when it comes to managing pediatric emergencies effectively. Next slide. And so pediatric care in the U.S. is becoming regionalized to highly specialized pediatric referral centers. And the overall goal for the regionalization is to improve quality and safety, of course, of care for our patients and to make sure that the patients get to hospitals that have the optimal pediatric resources and experience to care for those patients. But sadly, one of the consequences to that is unequal access to care, especially for the ones that live in medically underserved communities. Medically underserved areas have limited pediatric workforce and longer travel times to get to that specialized or definitive care. Next slide. And so we hear a lot, children are just little adults. Well, they're not, sadly. And so when it comes to caring for children, the requirements can be vastly different than those for adults. And those differences are sometimes really critical to know. One of the things that we need smaller specialized equipment to accommodate their size and unique needs. Medications are weight-based, and that's usually a newer or more difficult task for some of the hospitals that are used to caring for adults. And so your dosing has to be calculated very carefully, and a small mistake can have huge consequences for a patient. Of course, our disease processes and diagnoses are very different between children and adults. Children have a lot more that are just childhood illnesses, and it makes it a little more complex to diagnose and treat those if you're not used to caring for pediatric patients. Another key challenge that we have is all evidence-based research and management The practices often change more slowly for pediatric care. It usually all the research and the changes happen with adults first, and they slowly trickle over to the pediatric side, which makes it a little harder to keep up with those changes. And so sometimes that slow change of pace means that we have our risk for higher error rates with things, especially medications. And so the medication error rates can be as high as 64%. And so that's very alarming statistic for us to know how important it is to have careful, informed care for our pediatric patients. Next slide. And so, talking about caring for children in our state a little bit, Children's of Alabama is the only freestanding children's hospital in our state. We can provide the most comprehensive pediatric care, and we are the only hospital in the state that has certain specialized services, such as like ECMO and neurosurgery, just to name a couple. And a staggering 36% of our transfers come from smaller community hospitals, and that's much higher than the national average of 26%. So this means, of course, that children who need specialized care, they're coming from places where the resources just aren't available to them. And another challenge our state has, because it is a good sized state, is our round trip transport times can be extremely long, sometimes over 5 hours, and that's it can be due to not only distance, but if the weather doesn't permit the helicopter or a jet to go, and they have to go by ground transport, and that also extends that transportation time as well. Next slide. And so in our state, the gap in pediatric care is significant. 87% of the counties in Alabama are medically underserved, and we have 7 counties that do not have hospitals. And so, as you can see on the map on the screen, the counties that are in the yellowy color there have more than half of their population living in rural areas. The 7 counties without hospitals have little blue stars on those as well. And so we have 126 hospitals in Alabama. Most of those have emergency departments. We have some also freestanding emergency departments. 90 of our hospitals, however, have no inpatient pediatric services, so no way to admit a patient or hold a patient there for any length of time. 36 of these hospitals do have pediatric inpatient services, but they may not be true pediatric units. Sometimes we've realized as we go across the state that some of these hospitals will admit a patient, sometimes overnight or for a couple of days. They'll put them on an adult medical surgical floor. And even when they are like a little sicker or more critical, sometimes they'll even house them in an adult intensive care unit. And so it's hard for them to be equipped and staffed to handle the care that the children require. And then when it comes to critical care, 3 hospitals in our state do have pediatric intensive care units. And so those 3 hospitals are Children's of Alabama, that's in Jefferson County. For those of you that aren't in Alabama, it's kind of more in the center of our state. It's one of the urban counties there in white. We have a PICU in our Huntsville Hospital, which is located up in North Alabama in Madison County. And then the University of South Alabama Children and Women's Hospital that's down in the tip there in Mobile County. Next slide. And so these are actual comments that we have gotten from hospitals when they've called providers in our PICU, our ED, on our transport line. They're very stressed and very upset, and they just want help as soon as we can get it there. And they want us to really understand, hey, we can't take care of this patient and we need help. And so next slide. And so we were sitting and thinking, like, how can we help them? Instead of sitting here at the hospital saying, why didn't they do the things that they should do? Why did they do what they did? We thought, how can we truly meaningfully help them? Next slide. And so we thought simulation. To us in the SIM Center, simulation is the answer for every problem. And we have a wonderful simulation center here at Children's of Alabama, and we do simulation all day, every day. We do education for our environmental services workers all the way up to nurses and physicians. We do training to outside groups, nursing schools, pharmacy schools, and we even provide education for parents that are going home with their child having a new trach or a home vent. And we go through education and training with them so they feel able to take care of their child. And so we said, let's do simulation for these hospitals as well. Next slide. And so what is simulation? And so simulation is a powerful tool. We were able to use technology with our mannequins to recreate real life scenarios, including caring for critically ill children without having to wait for those real life emergencies to happen. And so this lets us practice, prepare, and of course, build confidence in a really safe and controlled environment. And more importantly, simulation supports experiential learning, which is learning by doing, which we know is highly effective for most adults. And it aligns with core adult learning principles. It's hands-on, relevant, and applicable to real-world situations. Next slide. And so does simulation work? So it's well known that simulated scenarios can uncover issues with current practices. It can improve knowledge and performance and decrease errors, ultimately improving patient outcomes. We like to approach simulation with a very non-threatening attitude and use it to work through issues during high emotional and cognitive load times. And we've seen that other outreach programs too have been able to improve relationships between specialty areas and the local healthcare providers. Next slide. And so, how do we develop a community outreach simulation program? So, we had the idea, we kind of knew what we wanted to do. We had to make sure we had staff and that staff had time dedicated to do the work that we wanted to do. And then we said, how are we going to fund this project? For those of you that don't do simulation, mannequins are very expensive, as well as a lot of other equipment and supplies are for pediatrics. And so we wanted to see, like, how can we make this happen? Next slide. So we were able to secure funding from a private donor. And so after that funding was secured, we got to work right away. We compiled a list of all the hospitals in the state. And from there, we researched and verified that we had phone numbers that would just call into the main line of the hospital. And so we sat down and we started calling, and we called in, we said, okay, let's try nursing administration. And so we asked for nursing administration, and we asked to leave a message or to get an email or a contact phone number. We asked for the CNO or a nursing supervisor, anybody pretty much that they had let us talk to kind of get to get our foot in the door and to start those initial conversations. We realized as we got into those conversations, and sometimes we would pivot and we would get new hospitals and we would call and ask for the emergency department. And so we just, a lot of work, a lot of footwork, and a lot of conversations. We introduced our program when we were able to get hold of people that are in administrative roles in the hospital. We emphasized our role was, of course, partnership. It was not about oversight. It was about getting in, connecting with them, collaborating, and then helping them with pediatric education and training. And so we were able at that point we started getting places, and we're finally able to schedule that first wave of site visits. Next slide. And so what is our program? We officially launched our program in January 2016 after, like I said, we got our foot in the door with the hospital in North Alabama through their CNO, that we were able to get on one of these mini phone calls that we placed to the hospitals around the state. And we, because of our generous donors, were able to offer this for free, which was our goal, is for them. A lot of the hospitals we know have low resources and don't always have funding for extra things such as extra education and training. And so one of our main goals was to be able to offer this for no charge. And of course, our goal and our mission for even starting the program was to improve care of pediatric patients in community hospitals throughout our state. And so our plan was to travel to these hospital emergency departments and inpatient pediatric units and provide assessments to their hospital, and also provide simulation education training. We utilize the Emergency Medical Services for Children Readiness Survey, and it does a assessment of the hospital as a whole to make sure that they have all the policies and procedures in place, and equipment and supplies and staffing in place to care for pediatric patients. Next slide. And so here's a quick glance at our team. Dr. Crystal Rutledge is one of the pediatric ICU physicians here at Children's. She is our program director. This is her dream. She is the co-medical director for our simulation center here as well. And Dr. Sarah Bingham joined us about 3 years ago. She's one of the pediatric emergency medicine physicians here at Children's, and she helps with the hospital portion of our project as well as our expansion into the EMS world. Dr. Lauren Robinson is also a pediatric emergency medicine physician here at Children's and joined us about 1.5 years ago to head up our outpatient and school readiness expansion, as well as to help with the hospital part as well. Ms. Carrie Norwood, along with myself, are the program coordinators for our program, and Eloise and Caleb are there. We got them in their clothes and took them to the hospital photographer for their school pictures that you see here, and they're also on our website. And you can, I'm sure you know how excited the photographer was to get those pictures for us. Next slide. And so our initial goal, of course, like I've said, is for emergency departments and inpatient units. But we revised our goal to improve pediatric care throughout our state, because as we worked with these facilities and we got more exposure to different people in these facilities, we said, wait, children are everywhere in our state, and how can we help everywhere as much as we can, everywhere that they are? And so that's where we expanded into our EMS portion. Mainly, like, we were like, kids are at home, they're at home, and when they have an emergency at home, they're going to call EMS. So how can we help EMS also practice and be more ready for children? Because pediatrics are intimidating if that's not something that you do every day. And then when kids aren't at home, they're at school. And so also that ties in with EMS, but how can we help the school nurses and help the school administrators make sure that they're ready for any kind of pediatric emergency? And again, EMS ties into that as well. We're working through the school systems, trying to figure out the best way to make their education happen currently. And then sometimes these pediatric patients present to their outpatient clinic. And so how can we also help the clinics be ready to take care of an emergency? And then also we can tie MS back into that. And so we were able to kind of expand our program a lot and have been able to reach a lot more areas, and are super proud of what we've done so far. Next slide. And so just a glance, the red dots are hospitals that we visited. You can see we've even been into Eastern Mississippi and Western Georgia. We also receive patients to Children's from those areas, and those hospitals reached out to us just word of mouth. They knew somebody at a hospital that we had been to and thought the program was super helpful for their facility and wanted us to also help them as well. And so we've been able to expand a little bit outside our primary reach. We've been to 60 hospitals. We go to these hospitals, they repeatedly. We have been to some of them numerous times. And so we therefore have had 162 visits, and this is just for the hospital realm of our program. We have some clinic visits and ECEMS site visits as well. And we have trained just on the hospital portion over 2,500 participants so far. Next slide. And so part of bridging the gap is understanding that this has been more than just simulation. Our simulation is our way to get our foot in the door, but it does help us provide them with education, and also show them that our purpose is not to criticize them, but to help them and to maintain a good relationship with them. We've helped them develop a lot of things. We have helped them with developing policies and protocols that they need in place for pediatrics that they haven't had before. And one request that we got as we have started going out more and more is they want to know about patients, real patients that they have sent to Children's. Sometimes the staff is really upset. Maybe it was a really bad trauma and they want to know how the child did, or they want to know how they did taking care of that child. And so we have been offering them feedback about real patients that they have sent to us through our critical care transport team. We sometimes, after our visits, we give a report to them about how the day went and what supplies or protocols or policies were missing according to the MSC survey. And so sometimes we've been able to be the voice for them. Maybe they needed more IV pumps, or they needed a clock in their trauma room, to keep track of times on certain medications and certain tasks. And so sometimes we've been able to help with that as well. And then we put together a pediatric management pathway binder that's tailored to the community hospitals. And so we have given that to them, and I will show you an example of one of those pages on one of the slides coming up. And so improvements are happening. It's not an overnight thing. They have a lot of staff turnover at these facilities, and so that ebbs and flows, and we know that we have to just keep trying and helping as much as we can and going there as often as we can to help with their education. Next slide. And so this is one of the initiatives that I was just talking about real patient feedback. And so it's just a screenshot of the follow-up form that we use to give them that real patient feedback. And so it includes that initial data with the patient information and the reason for the transfer. And then we give them a little clinical course. This is the patient that you had. This is why they came to see you. This is some things that happened while they were there. And then we give them transport information about us transporting them and how that went. And then after they get to children's, we give them information about what happened when they were here and kind of how their hospital stay went. And then kind of the end result, did they discharge or did something else sadly happen to them? And they have really loved this feedback. It has helped tremendously, we have seen, with care. Next slide. And so this another initiative, and I don't know if the picture is showing up for you guys. I don't see it on the screen. It is a picture that I had on here. There it comes. Of It's a page out of one of the management binder that we provided to them. We took any of our triage assessments, any of our protocols or pathways for sepsis. We did DKA. We did many different common things that these hospitals would see. And then we put it together and made it a little more generalized. We took out the children specific things and put in things that could work at any community hospital, no matter where you were. And so this is a guideline that, since we have given it to them, that they have been using, and they will call and they will say, hey, we've got this kid that's in sepsis, and we used your assessment tool, we're on your pathway, and we have done these things. And it just gives them that confidence to know, like, hey, I'm doing this exactly like Children's would do it if this patient was at Children's. And so they'll call and they have already given a bolus, and they've already given the antibiotics or things like this. And we have been able to see a change in patient care. And then we really wanted to see how else, besides word of mouth, could we tell if our interventions and our program has really improved patient care. And so, and I should have included a slide here with a screenshot of it, but we actually looked at DKA. We did some scoring and got some data and looked at how were the hospitals treating DKA after we provided our coaches program education for the first time. And then once they got the education, and then we started providing them real patient feedback on how they took care of the patient in DKA, we had a significant increase in the improvement of patient care. And so the percentage was shockingly improved. And so we were able to see our education and our feedback together were our best tool to help them with some of these diagnoses that they were struggling with for pediatrics. Next slide. And so, I'm sorry. So lessons learned. I'm so sorry. We've grown the program. We've learned a few critical lessons about what makes it successful. But first, it's essential when you're starting a new program. We learned early on to emphasize your needs and requirements right from the start. Our first several visits, we got there thinking that we clearly explained what we needed. to happen, but we would get there and the simulation would be, they would have us set up in a classroom or a conference room, or sometimes they have simulation centers they don't use, or in one of those rooms. And one of the things that we had to kind of step back and reevaluate that we were given enough information is the simulations actually need to be in a real patient room. And that realism is key. And so if we can get in that patient room where the staff can locate their supplies and their equipment and their resources in a space that they typically take care of their patients in, and in a space that they're truly comfortable in, then it makes the learning so much better. And then we also realized that we weren't clear about the participants needing to not have patience or to be able to be fully there for the entire span of the day. And so we would have people coming in and saying, "Oh, I got to check on my real patient." And so we didn't want anybody to have competing responsibilities. And so we wanted meaningful engagement so they could really buy into the realism that we try to portray with our simulation. And then one of our biggest challenges thus far and continues to be is prescriber involvement. And we feel like this happens for a lot of different reasons. Sometimes we get there, the prescribers that work in the EDs are not employed by the hospital. Sometimes they are contract workers, and sometimes they just live in completely other counties. And so when they come to work, they'll come and do their shift, but they don't have that true investment or buy-in for that facility. And so sadly, we know that we can have change, but we can't make the changes we need without the entire healthcare team to have buy-in. And relationship building and flexibility has been key. We try to really understand each team's culture and kind of what they're used to and where they come from. We give them our most of them I think have my cell phone number, and Carrie's as well. Our emails, our office numbers. They know that we, if something comes up, we'll try to be flexible if we need to reschedule, if we need to change and only do a morning session, not an afternoon session, or however we need to do to make it work for that facility. That's what we try to do. And anytime that they need us for support of any kind, then they call. And we do get emails and calls continuously about something that came up that they maybe don't have a protocol in place for, or that they don't have a policy for, or how do we deal with certain things. And then paying it forward, the more we empower these hospitals and their staff, um, the more growth that they're going to have and the better care our pediatric patients in our state are going to get. And that's what we want. We want them to be cared for so well that they are healthy and happy children. And we want these hospitals too to feel like we did everything we could on our end. And so they don't sometimes have that second victim guilt that they have if they feel like that they didn't do everything that they could. And of course, at the end of the day, we try to and never forget our why. And so our why is, of course, all the children that may be family members of ours or maybe friends of ours, but that's what keeps our mission clear and our work as meaningful as it can be. Um, Next slide. We want to shout out a huge thank you to our wonderful donors for our coaches program. Dr. Joe and Miss Cornelia LaRusa were our very first donors, and they did the majority of our funding for many years. And if it wasn't for them, we couldn't keep on doing what we're doing. And they saw our vision, and then they joined in and felt that same vision with us. And so we were able to get them on board. Mr. Mike Warren, one of the former CEOs of Children's, felt the passion as well and loved the program. And so he personally became one of our donors, the Pediatric Pandemic Network, and of course, the Children's of Alabama Foundation. Next slide. And so questions?
Stacy Gaither, incredible work. Would you share more insight on ongoing developments with coaches, outreach to public schools? Is this specific to school nurses?
It is not. It is one of our newer arms. We have a wonderful school nurse program here at Children's, and so we have been working with them to see how can we help the schools the most. And so the thing in Alabama is sometimes the schools will be maintained by the principal. And some of the counties, it's more an administrator, like a county administrator or someone in the Board of Education. And so we're trying to just help the schools in general. It's not just the nurses, but making sure the schools have, AEDs and different supplies. We're working with different people that already have programs out there. Um, the school portion is something that we're still trying to work through. So we haven't been able to start that completely yet. And so we're still working out those kinks, but it will be for the school as a whole and not just the nurse.
How did you secure the funding for this project?
Luckily for us, Children's being a nonprofit facility has a wonderful foundation. And so we contacted the foundation and we said, okay, so here's a project that we would really love to get started. Is there anybody that you could connect us with for this? And they knew Dr. And Miss LaRussa, and they said, we really let us pitch it to him and then see what he says. And he and his wife loved the idea because they are from here. He did his training here at UAB. And so we met with him and pitched the program, and he thought it was wonderful, and he donated, and so that's where we got started.
What was the biggest challenge that the program faced? I know you mentioned it earlier, but can you go back and review that?
Yeah. Like I said, physician and our prescriber involvement's been the hardest things. Some of the rural hospitals more toward probably more the Mississippi hospitals that we went to. They too have MPs that do telehealth. And so they don't have a physician on site. And so when we went there, their MPs were having to do all solely patient care. They didn't have extra people to participate. And then, like I said before, sometimes they're contracted in physicians or locum physicians. And so they don't have the buy in really for that facility. They do their shift there, but they don't have, that dedication to seeing the improvement there.
When you go out to hospitals, do you have specific topics that you do simulations, or is it dependent on what they're re- um, requesting? Do you have an agenda that you set in advance? And does it include other things outside of Situ Sim?
Yeah, we do. We give them an idea of, we usually talk to their like director of their ED or inpatient unit. And we say, is there something that you guys are seeing a lot of with pediatrics that you think they're struggling with or they need more help with? And then sometimes if they don't have any requests for a certain thing, we do a specific 3 or 4 scenarios when we go. And as we go back, we change those up. We always do a cardiac arrest. We always work through that with them because that's something they always want and need to go, to go through with. And we do a lot of debriefing with them after the scenario. So we go through diagnoses and treatments and suggestions for treatments that we would do. Keep it super non-threatening, but kind of just walk through everything with them. And so it can vary according to request, and if not request, what we have already in place that we're going to do. And we also sometimes they want to just us to bring some trainers and go through placing IVs in pediatric patients, and we'll give them a diagram of what that looks like and some more specific instructions for children and the different places that the IV, that the veins are. We work through IOs or different tasks if they have that too. We work a lot. We have a lot of requests for trach education. And so one of our mannequins can have a trach. And so we take a go bag and we walk through a lot of different like skills kind of training if that's something that they ask for.
We have 2 additional questions, but we've run out of time. So those that ask those questions will get the responses to you after the event. We want to thank you, Stacy, and your coaches team for your dedication and impactful work in rural hospitals. Your insights on teaching pediatric readiness are especially meaningful and personally appreciated. We thank you today, Stacy.
Thank you, guys.